Good morning. My name is Katy Tsai. I'm an assistant professor at the University of California, San Francisco in the Melanoma and Skin Cancer program. I'm here at ASCO 2023 in Chicago, standing at McCormick Place, and I am really excited to be here. I actually just came out of a highlight session for melanoma and skin cancer, and in the process of preparing that talk, we were asked to select abstracts that we felt were either very impactful on practice, or if not practice changing, at least in what way did it influence it, or what additional research questions might the study bring up. I think what was really interesting about the melanoma and skin cancers oral abstract session this year is that actually, in my opinion, I didn't really find that there was anything hugely practice changing. There wasn't that kind of one study that, for example, many years ago when ipilimumab plus nivolumab got approved for metastatic melanoma, it was a huge deal, standing ovation, and a very kind of distinct change in practice. This year, even though there wasn't that practice-changing moment, there was definitely a ton of interesting data, a lot of really interesting signals of activity of either novel drugs or drugs in different contexts or for different diseases that I'm looking forward to seeing where that goes. So maybe just as an example, and remember, this is melanoma and skin cancer, so not just melanoma. So for cutaneous squamous cell carcinoma, for example, this year in the oral abstract session, Dr. Charlotte Zur from the Netherlands gave a presentation about a neoadjuvant study randomizing patients with what was deemed unresectable or at least morbidly resectable CSCC, cutaneous squamous cell carcinoma, to either receiving nivolumab monotherapy or ipilimumab plus nivolumab combination. I think that in the melanoma world, there's been a very solid movement towards defining the clinical benefit of giving neoadjuvant PD-1, anti-PD-1 therapy, as opposed to just in the adjuvant setting. We've been lucky to be able to define a lot of clinical, to correlate a lot of pathologic results with clinical outcomes. And it's really exciting now that we know that PD-1 drugs like cemiplimab or pembrolizumab can affect, 50+% objective response rate in CSCC, to see that neoadjuvant movement going to the non-melanoma skin cancers as well. To the point where almost this got brought up in discussion the other day, it's almost not, the systemic, obviously I'm biased as a medical oncologist, but it's almost like it's not that we're giving neoadjuvant therapy. You could flip that around and say, as Paul Chapman did in one of the discussions, that the medical oncologists are giving the treatment, and then the surgery actually becomes the adjuvant treatment. So, our advanced cancer patients are getting treatment with promising immunotherapies, and then if they need excision of residual disease after, that's the adjuvant surgery that comes after. So kind of a neat way of thinking about that. So anyway, so Dr. Zur's presentation was not necessarily practice changing in the sense that it was a very small study, needs longer follow-up, better definition I think needs to be had about the treatment regimen and the number of doses given. But that adds to an already kind of building body of literature about neoadjuvant therapy for squamous cell carcinoma of the skin. It builds on an existing phase 2 paper already published in the New England Journal by Dr. Gross. There was an abstract this year by Dr. Paolo Asierto in Italy about using neoadjuvant and adjuvant cemiplimab in squamous cell carcinoma. So you're kind of sensing a theme here. Neoadjuvant moving from melanoma to the non-melanoma skin cancers, and we're really hopeful that it helps benefit patients and of course spare them from unnecessarily morbid surgeries.